I am John Cleland. I'm Professor of Cardiology at the University of Glasgow. So the IRONMAN study was an open-label, randomised trial of ferric dirysin maltose versus usual care in patients with heart failure and iron deficiency. Iron deficiency was defined as a serum ferritin of less than 100 micrograms per litre or a TSAT less than 20%, so you only needed one or other of those. We excluded people with higher ferritins above 400 micrograms per litre, and we excluded people who were either very anemic, because those patients would feel it was inappropriate to withhold iron therapy, and we excluded people with a rather normal haemoglobin because iron deficiency is quite uncommon in people who have a haemoglobin above 14 grams per deciliter. With the intravenous iron, we demonstrated, first of all, a rise in haemoglobin. Secondly, an improvement in quality of life at 4 months. And then long-term, a reduction in morbidity and mortality, heart failure, hospitalisations, and cardiovascular death. The study was affected badly by the COVID pandemic, and we didn't achieve statistical significance on the primary endpoint until that was adjusted for the COVID pandemic. And with that pre-specified analysis, we showed a benefit. The first thing I'll talk about is the clinical endpoints. So we looked at every hospitalisation and every death in this study. And the first thing that we found out that was quite interesting was that there was a significant reduction in all-cause hospitalisation. So it wasn't just cardiovascular hospitalizations that were being reduced, it was non-cardiovascular too. Looking a little bit more deeply into that, it did look as though it was respiratory infections and possibly acute kidney injury, that those were being reduced, so it wasn't just a reduction in heart failure hospitalizations. In the COVID sensitivity analysis, of course, also seeing a reduction in cardiovascular mortality at 1 year. So the other thing that we looked at was the iron biomarkers and what indicates response. And you can think of response in different ways. The first way you can think about it is the rise in haemoglobin that we saw. And the people who got the really big rise in haemoglobin were the people with a TSAT less than 10%, where they got a 2 gram per deciliter increase in haemoglobin with the introduction of intravenous iron. You then might say, well, what about symptoms? When we do that, it seems that the people who get particular benefit are the anemic patients. So if you were more than 1 gram per deciliter below the WHO definition of anemia, so that's less than 11 grams per deciliter for a woman and less than 12 for a man, those patients got, striking improvements in quality of life, measured with 2 instruments, the Minnesota Living with Heart Failure, but also the EQ5D, another quality of life instrument. But then, of course, you might be interested in morbidity and mortality. And then the picture becomes a little bit more strange. The first thing that we've noticed, and we've seen this in other studies as well, is that people with very low ferritins, less than 30, have a good outcome in the control group without even giving them intravenous iron. They do seem to benefit from intravenous iron, but they're at very low risk to begin with. So that's curious. The higher your ferritin, the worse the outcome. So that's a little bit curious. Then we look at TSAT, and then the information is a little bit more variable. It seems that we basically divided the TSAT roughly into quartiles. And it shows a little bit, it looks a little bit erratic what the response is. But then if you focus down on a particular group, which is the people with a high ferritin but a low TSAT, so these are people with a ferritin above 30, in fact ferritin above 100 and a TSAT less than 20, they seem to be super responders. They were getting 40, even 50% reduction in the primary endpoint. And that's unexpected, has to be verified in other data sets. But it's looking at the data, this seems to be a very consistent thing, whether or not you include the pre-specified COVID sensitivity analysis. So it seems that the ferritin, which we see as a marker of increased risk and perhaps inflammation, coupled with a low TSAT indicating iron deficiency, this is the group of patients who get the special benefit in terms of morbidity and mortality, at least, from intravenous iron. So different benefits for different populations. Well, I think we would like to know whether intravenous iron can reduce mortality or not. We saw some intriguing evidence in favour of that at the 12-month outcome in IRONMAN. So we're waiting for the heart FID study, and is that going to back up the reduction in cardiovascular mortality? I think we're looking to see whether other people find the same subgroup effect where there's this super response to intravenous iron, because that'd be very helpful. I think the IRONMAN tells us that it's TSAT less than 20% is the key marker to go for. A low ferritin is not helpful. Actually, it's a raised ferritin with a low TSAT that seems to be the group who really respond well. Then I think it's about implementation, and it's also about maintenance therapy. So if you are anemic and iron deficient, there's no doubt about it that a shot of intravenous iron is going to correct the problem very quickly and comprehensively. But about 1 in 3 patients the problem is going to recur over the next year. What we need to know is whether drugs like SGLT2 inhibitors, which seem to enhance iron absorption, are going to reduce that need for recurrent dosing. And I suspect that for people who respond well to SGLT2 inhibitors, there'll be less need for IV iron top-ups. The other question is, if you did, would you be better off with, would oral iron be enough? We have a little bit of evidence to suggest that we've been a little bit too negative about oral iron, that it probably does work, but it takes a long time to work. And of course, it may have more side effects than getting an intravenous iron. But for low-income countries that perhaps can't afford intravenous iron, then I think there's an argument for thinking about trying to increase oral iron. And then, is there anything else we can do? Yeah, I think there is. Jocelyn Friday, who's been working hard on this and has published some interesting data. Perhaps widespread use of PPI in long-term proton pump inhibitors is a problem. This reduces gastric acidity, may reduce iron absorption, and so it may be partly an iatrogenic problem, and it's always better if we can withdraw drugs and make people better as opposed to give them more.